Good morning, the fourth semester. Can you tell me, do you hear me and do you see the slide?
Yes, ma'am.
Yes,
You can
ma'am.
see the slide, right?
Yes, ma'am.
Okay. I give you a few minutes for the other students. I hope they will join us. Okay, for semester, I think we can start. Um, okay, let's see. If anybody will have a question, you can ask me after the ending of lecture. Okay, everybody hear me? Let's start. So yesterday we talked about the anatomy and physiology of the heart. So today we will talk about how to check our cardiovascular system. At the last previous semester, you have already uh, learned about what does mean inspection, what does mean questioning, how to make case history, how to understand this case history, how to check the patient by the palpation, by the percutation, percussion, and by the auscultation. So today we will talk about only the signs, symptoms that is belong to the cardiovascular system. So let's see. At this picture, if you see the picture, you can see how the doctor make palpation of the heart. So what is he doing? He actually try to feel try to examine or check apex impulse or apical impulse or PMI. I hope you already know what it is. Let's see. Okay, so in your cardiac history, what you will do. First of all, when you will meet the patient, what you ask the general questions, means the passport of the patient, like name, date of birth, and the address, and etc. etc. Last semester you know about it. Then you go and check them by the system. You check the respiratory system, you check the cardiovascular system, and put it in your case history. Because we are talking now about the cardiovascular system, so I will only explain this is history, and more to understand what kind of question to ask the patient of their heart disease, and what kind of disorders we will find in it. So let's see. So you see the presenting complaint or PC. We start from the complaining of the patient. I will show you. This is the next step is the history of presenting complaint. So it means the complaint that is located right now. So this should define the nature of the symptoms initially through the open questioning. Closed questions are used to elicit the presence or absence of the features which differentiate between the diagnoses. So before talking about the complaint of the patient, let's talk a little bit about the risk factors of the cardiovascular disease. So what does it mean? It means the reasons or the triggers or the factors that can influence to the disease. One of the most factors is the smoking. If you study in physiology, like the smoking influence on the vessels of the arteries. It is what to do. It is change the structure of the vessels. If you remember, arteries vessels consist of the layers. So innermost layer is the intima, and this is the intima can be changed by smoking a lot of years, a lot of times. So this is the one of the factors, and the doctors actually always fight with these factors. Hypertension, about the hypertension more in detail and the mechanism we will talk at the next lectures. Hypercholesterolemia, so what does it mean? If you remember, it is the dyslipidemia. So when the if you remember, we have bad lipids, we have good lipids, and when in the blood vessels grow up bad lipids and also change the innermost layer of the vessels, and what we will have, what kind of manifestation we will see. We will see atherosclerosis. Then another factors, it is the diabetes. I think it is the most dangerous. I'm sorry, guys. Okay, I'm sorry, guys. Diabetes, if you see in our days, this is the really, really horrible disease, and this is diabetes grow up every day. This is the if you study endocrine system, the diabetes, it is the what? Insulin changing disease. Then the next one is the family history of premature vascular disease. So it means of what in your family has the previous, what kind of disease did they have? Let's see. Okay, you also need to ask them about the past medical history, PMG. Like you need to ask, did you like have the stroke or transient ischemic attack, TIA? It means this is the like mostly TIA is the neurological disease, but you should to ask because this is the also happens from the hypertension disease, and you have to put it to prove your present diagnosis. Then renal hepatic fever, peripheral vascular disease, and other disease that is close to your cardiovascular system. Okay, let's see. At the family history, you should to ask what kind of cardiac disease did you have your grandparents, grandmother, grandfather, or your parents, mother or father? You should to ask not only what kind of, in what age did they have, and did you have the suddenly death in your family? Then because it will be like also high risk that you will have this disease at the future. At the drug history, you should include quantification of alcohol intake if a patient with non-cardiovascular disease is not taking the recognized standard treatment. The reason for this should be established. For example, why no statin treatment in a patient with a previous myocardial infection? So because it causes mass pain. What does it mean? It means when you ask the drug history, you should to ask, they say about the statin. You know the statin is the, you don't know, but you will know about the statin. Uh, it is the using and treating the cardiovascular disease. So you should to ask like what kind of disease did you use and why you stopped to use, or did you have some problems with these drugs and like this. For example, the bad side of the statin is it can cause the muscles pain, and most of the patients stop these drugs. Or if you have already seen that your grandparents have a hypertension, and in their hypertension they use the captopril or enalapril, this is the drugs, then the bad side of these drugs, it can cause the coughing of the patient. So, and some of the patients stop to treat with these drugs, and you need to put in your case history. Do not forget that this patient cannot use these or those drugs. Okay, let's talk about the complaint. So when you see the patient in any areas, in any specialist, they always complain of what's happening with them. So we are talking about the cardiovascular system, and you see the slide. Commonly, like commonly presenting complaint in these disorders, they are chest pain, breathlessness, or in Latin we call dyspnoea, palpitation when the heart is getting beat fastly, dizziness, blackouts or syncope when you what happened when you lost your consciousness, interruptions in the heart, cough and hemoptysis, and edema or swelling. So at the heart disorders or cardiovascular disorders, mostly you will listen, this is the complaint. And the most of the complaint is the chest pain. Let's see. But before talking about the complaint, you need to ask and some questions. Like when assessing correct symptoms, it's important to quantify the patient baseline level of activity because you need to understand in what of the condition this patient is located. So, for example, in patients with the chest pain, that the pain occurs with the climbing stairs, how many flights, how many steps, about with the walking like 50 feet, one block or more. What about carrying what about the carrying groceries, making beds or vacuuming? How does this compare with these activities now and the past? So you should to give the questions for the patient more too close to your diagnosis because mostly with the cardiovascular disease we have the categories of the old patient, and the old patient always starts to talk like a lot of things they can complain, but the doctors has to be dominant and start ask the questions more close to the disease. Okay, let's talk about the chest pain. Um, you see the slide, guys? You see the slide, I hope. Okay, so you see, chest pain is one of the most serious of all patient complaints. So, and accounts like for 1% of primary care outpatient visits. So, it is the most common symptoms of coronary heart disease. Shortly, the coronary heart disease we call CHD, which affects over 15 million Americans aged up 20 years. In, for example, previous years, the prevalence, it was like 7.6 million people. And on angina pectoralis, it was like 8.2 million. So HHD or coronary heart disease is the leading killer of both men and women. So in like SGD accounted for 1 in 7 deaths. Death rates remain high for black men and black women, and also in our nationality we also have a lot of problems with this disease, CHD. So as you evaluate your patient history of chest pain, always consider life-threatening diagnoses such as angina pectoralis or disease in aortic aneurysm, pulmonary embolus, or learn to distinguish cardiovascular causes from the disorders of the pericardium, trachea and bronchi, parietal pleura, esophagus, chest wall, and from the extrathoracic causes in the neck. So both men and women with acute coronary syndrome, we will talk in detail at the next lectures, usually present with the classic symptoms of exceptional angina. So however, women like over age like 65 are more likely to report the typical symptoms that may go unrecognized, such as upper back, neck, or jaw pain, shortness of breath, paroxysmal nocturnal dyspnea, or vomiting, fading, making careful history taken especially important. So let's see. Okay, you see the pictures. You see the pictures. You see the two different pictures. Two different pictures. They both have chest pain, but you can say one of the men, this is the man, have very bad chest pain. This is the man, not so bad. So you can identify by the face, by the conditions of what kind of chest pain this person has. In these situations, this is the person probably has a heart attack or acute coronary syndrome, and the patient suddenly can die. So it means acute, it means not chronic. In this patient, this is the not so sharp, severe, and this is the chronic, or did you hear about the angina disease? So this patient has this kind of chest pain. Okay, let's see. So you see in what kind of disorders or disease can happen this chest pain. And pay attention, guys. We have non-cardiogenic chest pain, which means not the belong to the cardiac disorders. And we have cardiac pain. So you need to identify this pain from non-cardiogenic pain and the cardiogenic pain. So what kind of reasons can cause this pain? One of them, and mostly, myocardial ischemia. And myocardial ischemia, angina, myocardial infarction. This is the mostly causes this pain. Look at this angina and myocardial infarction or heart stroke. They are belong to the myocardial ischemia. We will talk about this one, whereas ischemia. Then we have pericarditis. In Russian, we call ИБС, ХБС. So it means ишемическая болезнь сердца, ишемия. And we call КБС, коронарная болезнь сердца. Then the other reasons of this pain, it can be pericarditis when the pericardium is inflammation, aortic dissection, and pulmonary embolism. Okay, then you have to remember about the non-cardiogenic pain. It is the esophageal reflux, or musculoskeletal pain. Musculoskeletal pain. You know, some of the patients like confused. They come and say, "Oh, I have a pain. I feel very bad. I'm dying, and like this." But when we start to ask and differentiate it with the non-cardiac pain, then we see this is the mostly musculoskeletal pain. Okay, let's see. Myocardial ischemia. So myocardial ischemia, for this disease belong angina. In Russian we call stenocardia. In English, angina. So what is that? So ischemia of the heart results from an imbalance between myocardial oxygen supply and demand producing pain called angina. So look at this and learn by heart This is the definition because this is the reason of this disease. Look at this imbalance between myocardial oxygen supply and demand. So it means, do you remember when we talk about the vasculature of the heart? I say we have coronary arteries that is supply the heart. So, and this is the arteries also can have a problem. And one of them, what? One of them, this one, look at this. This is the normal artery. This is the lumen. And if you remember, arteries consist of the layers, and the innermost layer is the what? Intima. And it should to be very soft, nothing at the way or when the blood flow through this artery. And something happened with these arteries, but layer like this, atherosclerosis. Atherosclerosis is the most recent etiology of the angina. So look at this. Something start to grow up at the layers of the vessel, and how the blood will flow through this. Of course, blood cannot flow like normally, like fastly. Also, it will be have a resistance, and that's why it cannot reach. For example, this is the part of the heart, and if there is no blood supply, so there is no oxygen, so what will happen? Yes, we will see the pain in these parts of the heart. So that's why I'm saying to you, before learning the disorders, you have to know the normal supply. What LCA supply, what the parts, what RCA supply, what the parts of the heart. Okay, let's see. What you should to do, like a doctor, you need to describe chest pain. This is the very important. Describe chest pain. I'm sorry. Okay, so you need to describe the chest pain. How to do the describing? Because it is very important to describe this is the pain. You will identify what disease have this is the patients. So let's see. You need to ask the location of the pain. Remember forever, this is the scheme of the chest pain that is belong to the angina, The location, where is this pain appear? So you ask your patient, where is this pain appear? Then you need to describe character of the pain. Character, please tell me what kind of this is pain do you have? Then you need to ask relation to exertion. It means what caused your pain? When this pain starts? After what? When you start to walking or running or going upstairs, downstairs? When it starts? And you need to ask them duration of the pain. Duration, it means what time do you have this pain? like 5 minutes, 10 minutes, or 1 hour, and like this. So from this is the describing, from this is the questions, you will to understand what this patient have. So let's see. Okay, look at this. What do you see? The patient describes retrosternal pain. So it means when you see when you ask the location, if this is the pain, is the angina pain or ischemia pain, they will say, oh, doctor, I have the pain in the retrosternal. Okay, retrosternal they will never say, but they will show you where they have. They will show you, okay, here I have, doctor, I have here. So they will show you the sternal region of your chest. And you should to put in your case history, this is the pain is the in the retrosternal region. Here is, look at this. This is the we call retrosternal. Then you say to ask, this is the pain going anyway, like it is the go radiated. They will say, yes, it can radiate into the arms, throat, jaw. Look at this. This is the pink color. Pink color I show you. This is the radiation of the pain. Radiation of the pain. It means that some of the patient, they feel this pain in their arm. They feel this pain in their shoulder. Pay attention at the left side, because our heart mostly located at the, not located, they look at the left side. So they will say to you, yes, it is radiated in the left shoulder. It is radiated in my arm. And it is also can radiate in the jaw, left or lower jaw, at the throat, and also at the scapula. At the left scapula, they will say, yes, I have the pain, and this is the pain I see at the scapula. You know, I see the patient. I saw the patient when I did my practice. And someday come the patient and say, I have a pain in my little finger. I have a pain in my little, no any symptoms. He said, I have a pain in my little finger, and the left little finger. And we start to think, okay, what's happening? Why this patient can have this pain? And when we check the heart, when we the ACG, he has the stroke. He has the heart stroke of the heart, but he feel only the pain in the little finger of the left arm. So that's why you need to remember it, that the heart stroke or that the angina or ischemia of the heart can give the symptom not atypical. It can be atypical symptom. It can like feel only in scapula or in the shoulders, or they can say, I feel the pain in my lower jaw. I feel the pain in my teeth. And you will think, okay, what's going on? Teeth is everything is good. He goes to the dentist say, oh, everything is good. But he said, I feel the pain in my teeth. And remember, it can be heart stroke. It can be angina or ischemia of the heart. Then it has constricting character. Constricting character. So you need to describe what kind of character this pain. They will say, not sharp. If they say, I feel like sharp, severe, and it's accompanied with the fever, so remember, this is the pain of the heart attack. If they say, no, I feel like something is like constrict in my chest, like some animals or cat pushed your chest, and constrict your heart, it will be like this pain. Then the very important is the what is provoked this pain, and actually is provoked by exertion, relieved within minutes by rest. Like it can like they can say I have the pain like 5 minutes, 10 minutes. Then when I have a rest, this is the pain stop. Or they can say it starts. Then I put nitroglycerin. This is the drug the patient put under the tongue, and my pain stopped. So guys, it means this the patient has the ischemia, but the patient can say, "Oh, doctor, my pain starts and it go like 15, 20 minutes." And you will like thinking, okay, this is not an ischemia, this is not a heart attack. Or you need to differentiate it from musculoskeletal pain. Mostly when the patient has the musculoskeletal pain, they will say like, I have a pain like 24 hours. I have a pain 2 days. This is the impossible for the heart attack or engine disease. Okay, here is acute coronary syndromes. We will talk more in detail in these syndromes, but this is the heart attack, and I want to show you what the difference is. So when you see the patient with these faces, look at the man, he feel really bad and he feel really pain. So probably he has the acute coronary syndrome, heart attack. So what's happening? The pain is similar in location and character to angina, but it's usually more severe. Remember it forever. And this syndrome, it will have more severe, more prolonged, and unrelieved by rest. Acute pain, accompanied by a feeling of fear of death, called sticky sweat. And what happened with the patient? The patient will say to you, "Oh, doctor, I think I will die." Yes, they will do this condition. It will be very severe pain, not like a patient pain, and they will say, "Oh, they will afraid of death," and they will say, "Oh my God, I'm dying," and the cold, sticky sweat will go through his face. And also, nitroglycerin never helped to stop this pain. So it means this patient has the acute coronary syndrome, and it's really extremely, you have to help this patient, or this patient can die, because this is the pain like very, very strong pain, and nothing can stop this pain. And mostly patients die because of pain. Why? Because there happening thrombosis in the vessels. The vessels, coronary artery, blocked by thrombosis, and there is no supply of the region of the heart. If in the chronic ischemia or chronic coronary syndromes, or in the angina, if there is a little bit supplying of the heart, but in these situations, like there is the stop supplying of the parts of the heart. Okay, this is the, I show you pericarditis. Pericarditis, this is also disease of the heart, when the inflammation inflame the layers of the pericardium. I hope you remember pericardium. This is the outer sac of the heart, where is the our heart is located. So this is the caused central chest pain, which is sharp and in character and aggravated by deep inspiration, cough, or postural changes. So you see, in these situations, your pain also will be sharp, and but they will be changing the character by the inspiration, and the other symptoms of the pericarditis you will see. Then aortic dissection. This is that produces severe tearing pain in either the front or the back of the chest. And the onset is abrupt, unlike the crescent quality of the ischemic cardiac pain. Then also you need to understand the pulmonary embolism. Pulmonary embolism causes sudden, sharp, pleuritic chest pain, breathlessness, and hemoptysis. So central pulmonary embolism presents with the breathlessness, chest pain that can be indistinguishable from the ischemic chest pains and syncope. Risk factors for the pulmonary embolism should be sought in the history. So um, here we go. Mitral valve disease. What kind of pain you will see if you will have mitral valve disease. So this is the cause discomfort in the back, sometimes associated with the dysphagia. I hope you know what I mean dysphagia. Dysphagia, it means cannot swallowing due to the esophageal compression. Aortic aneurysm can also cause pain in the chest owing to local compression. Okay, so we done talking about the chest pain, and please write in your notebook because it is the most commonly complaint. The other complaint, like dyspnoea, cough, and the hemoptysis and the swelling or edema, this is the symptoms of the heart failure. So let's see, what does mean dyspnoea? What does mean dyspnoea? It is the breathlessness when the patient cannot breathe. So let's see, is an abnormal awareness of the breathing occurring either at the rest or at an unexpectedly low level of exertion. It is the major symptom of many cardiac disorders. And mostly this is the what? Heart failure. If the pronunciation is wrong, I'm sorry. In Russian we call сердечная недостаточность, heart failure. So let's see. So dyspnoea, choking, cough, edema, or swelling are the most important clinical sign of heart failure. I will explain you why. Heart failure, this is also a syndrome, and we will talk more in detail in the next lectures. But what's happening to the heart failure caused by the disease of the heart, for example, by the angina or arrhythmia or the chronic disease of the heart can come to the complication, and we call heart failure. So this is the heart failure, and you see the symptoms dyspnoea, cough, edema, because when the patient, okay, breathlessness. I will show you the. Okay, here is. When the patient, you see the patient, he has the heart failure. Why? Because he cannot lay down on the horizontal supine, on the horizontal direction. Why he cannot? Because increases venous return when the patient lay down. The pressure is increases, and this is pressures go, if it's like left ventricle, then it go to left atrium, then it go to the pulmonary circulation. If you remember the circulation, pulmonary, systematic, how it works, so you understand why this dyspnoea comes. Okay, but now remember, Dyspnoea, choking, cough, edema, or swelling are most important clinical sign of the heart failure. Edema. Look at this, the leg. Look at the leg. You see, this is the normal leg, and this is the abnormal, and we call this is the situations or symptoms edema or swelling. So edema starts from the ankles and above, worsen in the evening, combined with the shortness of breath and cyanosis. So remember, the swelling in our body can occur because of the heart failure or kidney disease. If your swelling starts from the ankles, from the feet, and go up, so from down to up, and it is like bad conditions at the evening, so it is, we call the problem lies at the heart. If your swelling appears at the morning and start from your eyes, face, and go down from up to down, so it is the probably kidneys disorders. Okay, about the edema and swelling, I will show you and describe here in the inspections. Okay, you need to write down in your notebooks common symptoms of the heart disease. They are chest discomfort or chest pain, and what kind of disease can cause a myocardial infarction, angina, pericarditis, aortic dissection. Then other causes, esophageal spasm, pneumothorax, musculoskeletal pain. So you need to differentiate it from the cardiovascular causes and other causes. And remember that this is pain can occur in these situations. Then the other symptoms is the breathlessness or dyspnoea. So when look at this heart failure. So mostly it is occurs because of heart failure. Valvular disease, angina, pulmonary embolism, pulmonary hypertension, and the respiratory system. We will discuss more in detail what has mean pulmonary hypertension, embolism, and how this is the breath comes. Then other causes, respiratory disease, anemia, obesity, anxiety. Palpitation. So palpitation when your heart start to beat very, very fastly. It is also can have the cardiovascular disorders, these symptoms when tachyarrhythmic condition, or if you hear the tachycardia, and it can happen from the thyroid glands disease. Then also it can happen by the myocarditis disease when the myocardium layers inflammation. Then it can happen by anemia when the hemoglobin go down, and the patient, sometimes the patient comes in like, oh, I have a tachycardia, I'm dying, please let me stay at the hospital. And we're like, okay, wait, can we check your heart? And when we start to check the heart, and we will have a question, and then we understand what's happened. This is the yes, she or he has the tachycardia. But the reason of tachycardia, anemia, the anemia, when the gamma globin go down. And of course, there is no perfusion, no supply, or the supply is like slow, and it will seem that your heart wants to go outside. So that's why you need to differentiate it, everything. Then also it can cause by the anxiety, hyperhidrotism, also by using the drugs, syncope or pre-syncope, or it is can cause by the arrhythmias, postural hypertension, aerobic stenosis, hypertrophic cardiomyopathy, atrial myxema, and other causes. Here, simple faints. Also, we will talk about it in this disease and the swelling. So mostly happen by the heart failure, constrictive pericarditis, venous stasic, lymphadenoma, and other causes. Nephrotic syndrome, liver disease, drugs, immobility. Okay, it was only complementation of the patient. The next step, we go to the inspection of the patient. What does mean inspection? Inspection means examining, means watching. Okay, so you are standing in front of patient, and you see. The inspection, it means what you see in the patient. If the patient standing in front of you, thank you so much, he is alive. The first of all, you need to understand this one, because in some conditions can come not standing, they can come with the ambulance, maybe in these situations when he's between the death and life. So that's why if the patient come by his food, thanks God he come by his food. And what you see to check in your case history. First of all, you need to see the patient position. If we're talking about the cardiovascular system, so patient position in this system, mostly you will see orthopnoia. In Russian, we call orthopnoia. I'm sorry if my English pronunciation is not good, but this word comes from the Latin word. So all our medicine comes from the Latin. Orthopnoia. What does mean orthopnoia? You see the man in the picture. This is the position orthopnoia. And here is orthopnoia. Don't forget, fourth situation. This is the fourth situation. What does it mean? The patient can stay in these situations whole 24 hours, whole week, and like this. So this is the four situations: sitting in armchair or in a bed, with a raised head, hands on the knee. On the knee. Look at this. Here is the man. How he's sitting. His knees and hands go down. So why he cannot lie down? Why? Look at this. He cannot. Even when he lie down, he will use the pillows. Look at this picture. When you go to hospital and when you see the patient using a lot of pillows, you need to understand, or this patient has a heart problem, or this patient has the lung problem. Look at this. So it signifies advanced disease or incipient decompensation. What does it mean? So this is the position happened in the heart failure. In the heart failure, when the patient has, like, for a long time the heart problems, and it comes to decompensation. Please read from book what has meant decompensation and what has meant compensation. Then what happened when he tried to lie on his bed? What happened? Lie flat or in a horizontal position. Increases venous return in patient. So look at this. Increases venous return. What does it mean? It means like when the patient lie on the bed, What happened? Do you remember the pulmonary circulation? So your blood, not the patient blood, will pressure grow up from the left ventricle to the left atrium and go to the what? To the pulmonary arteries and go to the lungs. And what happened? And happened stagnation of blood in the lungs. So this is the swallowing the lungs, in other words, or the fluids go to the interstitial spaces. So that's why he cannot breathe when he go and lie at the bed. He cannot breathe. That's why he's sitting. He's sitting because he need to breathe. When he lie down, this is not happening. So with the left ventricular impairment may precipitate pulmonary edema. And look at the 3 pillow they can use. Look at this. So patients may choke or gasp for air, sit on the edge of the bed, try to catch the air. It may be confused with the asthma and open windows in air attempt to relieve their distress. So 2 pictures. This is the heart failure. This is the bronchial asthma. You need to differentiate it in what situations you will see the heart failure problem. That's why he cannot breathe. Or he cannot breathe because he has the bronchial asthma. You will start understand the differentials when we'll study bronchial asthma. But see the differentials in this picture. Look at this, how he is sitting. He is sitting at the edge of the bed, and look at this. He tried to grow up his shoulders muscles. He tried to breathe with the muscles. In the bronchial asthma, the muscles start to work because the genesis of this disease is different. But look at this. His shoulders is up. With the heart fluid, there is no shoulders using. But this patient tried to catch the air by using the muscles of the chest and shoulders. Here is the differences. Okay, in this slide, I try to give you in what condition can appear these 4 situations or orthopnea by the heart failure, decompensated heart defects, left ventricular aneurysm. But if the patient have the pericardial effusion, what he will do? The patient will try leaning forward or in the knee elbow position. So that's why in the previous semester, you should to study what kind of position of the patient do we have. So for the cardiovascular, we have the orthopnea position. Mostly you will see. Okay, so the patient come, you see the position, or you go to the patient and you see the position of the patient. The next one, what you will check or inspect the skin and mucous membrane. I think you have already known about the cyanosis from the last semester, but I give you remembering. Cyanosis, what does mean cyanosis? In Russian we call cyanos. So this is the blue discoloration of the skin and mucous membranes caused by increased concentration of the reduced hemoglobin in the superficial blood vessels. So see, this is the cyanosis. Look at this at the finger. This is the blue discoloration. Look at this cyanosis. Look at this, the mucous membrane. You can say, okay, open. If you don't understand what color of the lips, or you cannot understand where is the cyanosis of the skin, you can say, open your mouth and show me your tongue. And when the patient open his mouth and show you the tongue, you will exactly say this is the cyanosis or there is no cyanosis. if you remember, we have peripheral cyanosis and we have central cyanosis. Peripheral may result when the cutaneous vasoconstriction slows in the blood flow and increases oxygen extraction in the skin and the lips. Central cyanosis, what is this? This is the may result from the reduced, may result from the reduced arterial oxygen saturation caused by the chronic or pulmonary disease. It affects not only the skin and the lips, but also the mucous membranes of the mouth. So you need to identify what kind of cyanosis this patient has, peripheral or central. Then also, with the heart disease, you will see these conditions. What you will see? Look at this. You can have acute cyanosis. What is this acute cyanosis? Acute cyanosis, it is the what with the chronic heart failure it occurs. Acute cyanosis, and actually, okay, acute cyanosis actually, this is the getting the blue color of your feet and hands when the what? I think I have. Oh, here is. Yes, I have a picture. Here is acute cyanosis. Look at this. What's happening? Is it typically symmetrical? So what does mean is it typically symmetrical? It means both legs will have symmetrical acute cyanosis. Because you can have the patient when one leg is in acute cyanosis. Oh, no, I'm sorry. One leg is the like blue color, other leg is like a little bit blue color or no color. So it means this patient have a problem with the veins. For example, with the this patient has the thrombophlebitis or thrombosis of the veins. This is the not cardiovascular disease. But in the heart disease, the acute cyanosis is the typical symmetrical. So you understand acute cyanosis is the contracted of the what? Of the veins of the feet and hands. So look at this. It is marked by a motile blue or red discoloration of the skin on the fingers and wrist and the toes and ankles. So profuse sweating and coldness of the fingers and toes may also occur. Acute cyanosis is caused by the narrowing constriction of the small arterioles, tiny arteries toward the end of the arms and legs. So see, if you will see this condition, then very important to feel the temperature of the skin. You touch and you feel cold and warm. This is the acute cyanosis. If it is cold, so this is the heart disease. If it's warm, it is the pulmonary disease. So that's why they're saying profuse sweating and coldness of the fingers. Coldness, why? Because the what? Arteriole is constricted. Because there is the vessels constricted. But why in a pulmonary disease they're warm? There also has these situations, acute cyanosis, but they're warm because in the pulmonary disease there is the CO2 or dioxygen carboxide. Do you remember carboxide? Carboxide is increasing in the vessels, in the blood, and it gives the warm temperature. We will talk in detail, no worry, in the pulmonary disorders. So remember, acute cyanosis, it is the result of heart failure. Remember this one, heart failure. Then you can see, except the acute cyanosis, you can see pronounced cyanosis. Pronounced cyanosis, what does it mean? Very much cyanosis. This is with the narrowing of the mouth of the pulmonary artery, pulmonary sclerosis. It can cause, you can see local cyanosis. Local cyanosis, I have already tell you, it is happen in the thrombophlebitis of upper or lower extremities, and you can have isolated cyanosis of the head and neck. Isolated cyanosis of the head and neck. When it's like happening the compression of the supervena cava. Supervena cava. Okay, let's see. Then you need to check the colors of the at all pallor of the skin and mucous membrane. Pallor, I hope you know what does mean pallor. It can happen in aortic defects. Then you can see the color of coffee with milk. Coffee with milk. I hope, did you drink this coffee with milk and what kind of color it is? It can happen in the septic endocarditis. Very, very dangerous disease. Then you also can find the signs like petechial and hemorrhagic rashes on the skin and conjunctiva. It happens also in the endocarditis septic. Here is all this information: Osler's notes, hemorrhages in nail bed, and rash roth spots. You will find in your book, MacLeod's books. Here is these situations. Here is, look at this, hemorrhages of the conjunctiva. Look at this, or hemorrhages of the nails bed. Okay,